Welcome, everybody. It gives me great pleasure. I'm Chris Abbott. Most of you guys know me. It gives me great pleasure to introduce Dr. Paula Hensley. Dr. Hensley is a board-certified psychiatrist from the Chicago area, completed her residency, a psychiatric residency at UNM. She has worked in a variety of psychiatric settings, including inpatient, outpatient, psychiatric emergency services, and rehabilitation services, nursing home across various geographical locations, including UNM, private hospitals, state facilities, and private clinics. And to really emphasize this, I don't think there's any other provider who has some more varied clinical experience than Dr. Hensley. We are fortunate because she recently returned to training as a geriatric psychiatry fellow, and she'll complete the program at the end of June. Just prior to returning to clinical medicine academia in 2023, she spent several years working in behavioral managed healthcare. So without further ado, I introduce Dr. Hensley, and she can take it away. Thank you.
All right, thanks, Dr. Abbott, and thank you for inviting me to do the fellowship. I think I would still possibly be languishing in the managed care world if we hadn't had that conversation some years ago. So I appreciate you and the department, Dr. Towen, for allowing me to come back to UNM. It's been a great decision. So today I'm here to talk to you about insurance, kind of how to navigate that for your patients, how to help them, how to advocate for them. And I do want to leave time for questions. I have quite a few slides. And so if I don't really get a lot of time to answer specific questions, I do invite you all to email me, just ask me if there are ways that I can be helpful and try to figure things out. Because even having spent that time working for insurance, I have to say it's not an easy area to navigate. And even as a professional, I've had to advocate a lot for my family. And had I not had that experience, I wouldn't have been able to do as well. But even so, there are a lot of things I don't know, and always willing to learn from others and their experiences. So in deference to the fact that I'd rather be drinking coffee right now, I am drinking water. And Dr. Abbott and I share that love of coffee. Okay, so here's my title. I have no relevant financial relationships with any commercial interests. I have some learning objectives, and these are in the announcement as well. And so hopefully you'll be able to get something out of this. It'll be a fairly practical guide with some, literature review, but really trying to do this as a practical strategy and toolkit. So I'm going to start off just with a case. And this was a pharmacy prior auth case that I dealt with upon my return to the clinic and working with Dr. Frazier in the START clinic. There's a gentleman who has depression and persistent depressive disorder. And he was prescribed aripiprazole in the past as an augmenting agent, which led to tardive dyskinesia. He had tongue and forehead, eyebrow movements. He was very self-conscious about it and was experiencing increasing social isolation because of these effects. So I just want you to think about what would be your next steps for this patient. He's no longer on the aripiprazole. He has depression, which is, partially responsive to medications, but really being influenced by these abnormal movements, which are a known, side effect of the medications. Okay, so just to kind of give you a basic orientation to insurances, Medicare and Medicaid are the government programs, and they have different eligibilities and coverage. And so this can be confusing. I realize that a lot of people at the VA, this may not, if you're watching, this may not be a particularly relevant talk for you, but some of your patients will have Medicare coverage. And so I'm hoping that I can make this partially relevant to you all, but much more so in the private sector and at UNM. We're dealing with a lot of people on these government programs. So Medicare is the program that's administered by the government. It's for ages 65 and over, and some disabled persons. I know in the past when I would have someone who was deemed disabled by the Social Security Administration, they usually had about a 2-year wait, and then they would be on Medicare. And then also some individuals with end-stage renal disease are also eligible for Medicare, generally federally funded, and there are penalties for late enrollment. So if your patients are asking you about enrolling in Medicare, make sure that they know that they need to get on that as soon as they get that letter, because it's very confusing, and there are agents out there and 800 numbers. I don't usually advise people on how to enroll in Medicare, but I would really encourage them to make use of those resources. And I think there are some good agents out there who can help them navigate that. Medicaid is our system for low-income individuals, children, and disabled. It's federally and state funded and requires periodic recertification. And I know that we're in a very tumultuous time. We don't really know what's going to get cut, Medicare and Medicaid. This is all really up in the air right now. But hopefully our patients will continue to get the high rates of Medicaid coverage. New Mexico is the highest percentage of people on Medicaid in the country. At about 42% of people get Medicaid coverage, and so just kind of advocating for them, making sure that we're helping them get all the resources and the coverage that they're entitled to. So Medicare options really are very confusing. So Part A is your hospital insurance, Part B, the medical insurance, and then Part D is drug coverage. Medicare Advantage is considered Part C, and then many people will buy a supplemental policy, which, like the VA offers for employees, the Blue Cross government subsidy supplemental coverage, which is really one of the best insurances I think you can get. My mother was not a VA employee, but a state of Illinois government employee, and that's the insurance she had. And toward the end of her life, it was really a godsend to have that insurance coverage. She had a lot more benefits than someone with a Part C or regular straight Medicare, traditional Medicare. So many of our patients will have dual eligibility with Medicaid. And so if you have someone who comes in saying, oh, I don't need my Medicaid anymore, I'm not going to bother to recertify, and I now have Medicare, really encourage them to keep the Medicaid, because Medicaid will pick up the things, the coverage for medications, for services that Medicare does not cover. And Medicaid will require a letter of denial from Medicare in order to cover. So, like the state of New Mexico has pretty good Medicaid coverage, and some additional benefits, for example, that we have in New Mexico are the patients with Medicaid will have transportation to appointments. For Medicare, they'll have some allowance for over-the-counter items, and long-term services are usually what's covered by Medicaid, not Medicare. So Medicare will provide short-term coverage for rehab, physical therapy, occupational therapy, speech therapy in a rehab center, like a skilled nursing facility after a hospitalization. But those services are typically limited to about 20 days. And people with that supplemental coverage can continue to get long-term care services on a short-term basis. It's a little bit of a misnomer, but they can get continued rehab. Whereas someone who just has straight Medicare or might have a supplemental or Medicare Part C and Medicare Advantage, they are not going to have much coverage beyond that 20 to 21 days unless they want to pay about $150 copay, which for many people is too much. So Medicaid will pay for some personal care services, might pay for some assisted living, depending on your plan and depending what the individual's income sources. So if they're on disability income, they may have enough money to pay for the room and board at an assisted living. And many of the Medicaid, the managed care organizations here in New Mexico will have contracts with assisted living facilities. And it is pretty hard for our mentally ill people to get into those facilities, but that may be an option for some of your patients. Some of the managed care organizations here in New Mexico will also offer value-added benefits, and so they may bridge someone, to go to assisted living while they're waiting for their disability income to kick in. And so there are a lot of, really kind of details about this that really I didn't discover in my role until pretty late in the course, because I was always told, oh, Medicaid doesn't pay for assisted living. Well, not exactly. They do pay for the personal care services, and sometimes the assisted living homes will actually have their employees provide those personal care services, but the room and board has to be paid by the patient. And so that would be if someone, has a family member who can help out, or if they have a decent disability income, which, some of our patients really do have. And depending on the assisted living, they may be able to negotiate what that room and board is. So just keep that in mind. I only really discovered that about 4 years into my work, because I had a patient who went to an assisted living following her hospitalization and severe COVID infection, and I knew she didn't have a lot of money. And so I really had to trace it back, and then found out about these contracts that we had been kind of kept in the dark about. Care coordination is something that is really promoted by the state of New Mexico. It's usually, these are usually employees of the insurance company, and their role is really be there to help the patient access care. And so they can be a great resource for you all. And whenever I have a patient who has Medicaid, I ask if they have a care coordinator and try to get them hooked up with a care coordinator. That's usually by calling customer service. And if it's someone I know, I can usually kind of contact them directly, but that's fewer and fewer of the patients now that I'm focusing on older people. Medicare and some of the commercial plans also have care coordination, but it's more over the phone. And so someone has to be really a lot more functional in order to participate in that. Whereas Medicaid, the care coordinators are really tasked by the state to be, kind of boots on the ground, going out, seeing patients, and really helping them access care and trying to minimize overuse of resources. And, my experience with these folks is that they are some of the most dedicated people that you'll meet working for insurance. They're incredibly kind. They may not have a huge background in behavioral health or in healthcare in general. Some of them are, ex-parole officers, or they might have been psychology majors in school. Some of them don't even have college degrees yet, work very well with people. And they're able to call on peer support workers to kind of help patients who are having a hard time, kind of being in the system, maybe resistant to the idea of mental health care. So, care coordination, great resource if a person has Medicaid. If someone is having trouble accessing the transportation to appointments and they have Medicaid, the care coordinators can help them do that. So just kind of keep that in mind as another source of help for your patients. All right, so Medicare Advantage plans, we're supposed to reduce costs and offer additional benefits to patients. This was established back in 1997. And the companies who administer their plans get fixed payments. So the payments are supposed to cover additional services for patients. So the patients really like them because they can get dental assistance, vision assistance, hearing, gym memberships, the silver sneakers, if you've heard of that. That's, who is usually providing that service for the patients. They're usually on a Medicare Advantage plan. But there are some negatives, which we'll go into. But oftentimes people don't realize when they sign up for a Medicare Advantage that they're really being restricted in their network that they can use. So like, for example, Presbyterian here in town has a Presbyterian senior plan that really is focused on care in New Mexico. And so for people who want to get care outside the state, say they want to go to the Mayo Clinic or something like that, it's harder for them to get that paid for by Medicare Advantage. Whereas if they're with a national company on an Advantage plan like Blue Cross, they can access those services because, say the Mayo Clinic might be a network. So there are some nuances there. None of these plans, Medicare plans, really pay for services outside the country. So if people are doing a lot of travel outside the country, they should consider getting medical insurance to cover that. Although, anecdotally, I've heard of people going out of the country, not having that insurance and having much more access to services and not having huge bills for the services that they do get. But if someone is, say, splitting time between here and Arizona, a New Mexico focused Medicare Advantage plan that, limits the network to New Mexico doctors may not be the best choice for them. Okay, so when you look at the there have been a lot of data and kind of papers in JAMA just within the last few years looking at these Medicare Advantage plans. And the data about whether you can really reduce costs without causing harm is kind of in flux. So there's studies kind of on both sides that will, kind of show you, yeah, there are more problems if you're limiting care because of Medicare Advantage. And then there are some studies that show really it makes no difference. So I think that question is still up in the air. So on the left side, I just have a couple of studies. These were all from kind of referenced in this article down at the bottom there. But there was an AMA survey in 2023 of physicians, and physicians were asked, how many of you all know of a patient who had some serious consequences to a delay or a denial in care? And so 25% of physician surveys said they knew of serious adverse events because of these denials. 13% of the physicians said that these were life-threatening events, and 7% noted that they knew of at least one patient with a permanent disability, birth defect, or death because of denials. The KFF, which used to be called the Kaiser Family Foundation, they shortened their name to KFF, but in 2023, they found that patients who had these denials experienced a 3-time greater delay in costs or in delay in care, and 2 times higher rates of health decline with those denials. And then on the other side, in 2017, there was a study that showed that there were lower readmission rates in spite of less post-acute care with Medicare Advantage plans following an index hospitalization. And then a more recent study cited by JAMA, one of the JAMA affiliate journals in 2024, showed that people who were hospitalized but switched from Medicare Advantage to traditional Medicare had shorter post-op rehab stays, but that they showed no greater readmission or mortality in the short term, defined as like 30 days. So really, it didn't seem to make much of a difference that they had shorter post-op rehab stays. Okay. I'm just checking my time. So the rate of underinsurance with Medicare is about 20% overall. So even for people who are 65 and over, who have Medicare coverage, many of them are reporting that they feel underinsured. And so this is part of the affordability problem with Medicare, with supplemental coverage that can run into very high costs for people. But the real risk is, are they are they delaying care? Are they avoiding care because of these costs? All right, so that is, this is just a breakout from the KFF of people, in spite of being insured, the rates of foregoing care because of that. So they're delaying care, or they're going without care because of high costs. Now in New Mexico, people do not have, like, Medicaid, on Medicaid, do not have copays, do not have insurance premiums, but that isn't, consistent throughout the United States. I know of, like, in Illinois, just because I'm aware of some of the issues there, they've had a real problem with funding. And so I believe that they're charging premiums for people on Medicaid. So it's not consistent across the country that there are no copays. And that could be something that other states enact with Medicaid cuts. All right. So obviously the pandemic brought about a lot of bad things for our patients, but also some good things. So there's greater access to virtual visits. That's a little bit in flux right now, whether Medicare will keep paying for those, whether they'll continue to pay for phone only. I think there's something released as recently as this past week that I haven't digested yet. But there also have been some expansion in substance abuse services. So in New Mexico, we have greater access to rehab stays and lower levels of care, like residential care for patients that we really didn't have before. And then there's, of course, a reduction and elimination of a lot of copays for mental health services. But, I still have patients on Medicare talking to me about foregoing medical care because of copays, trying to limit the amount of visits they have just in general because their copays are fairly high. And then, of course, on the negative side, greater isolation of people and the shortage of healthcare providers, drivers. That's still a big problem on Medicaid. They do have access to safe ride services, but do they have a driver? Sometimes they're using like Uber and Lyft to provide that driving assistance, and that can work for some people, but not for people who need medical transport, like from ECT or from a procedure. And then of course inflation. So kind of going back to my patient who had tardive dyskinesia, has tardive dyskinesia, in review of his chart, his Ames was normal at the medication start. And then by the time I took him over, he had mild to moderate facial and tongue movements. And aripiprazole had been stopped. It had caused tardive dyskinesia, and his depression was unchanged. So it really had not made an impact on his depression from review of the notes. And his aim 6 months later remained the same. So in spite of being off the medication for some time, when you stop the medication, sometimes the movements will increase, but sometimes that will improve over time. It had not. And so, think about what you would do for next steps. All right, so this is my little commentary on how hard it is to sometimes find the formularies for these plans. So I have had more than one outpatient pharmacist when I call them and try to figure out, whether a medication is on the formula. They say, well, just put the prescription through and we'll see if it goes through or it needs a prior authorization. So, that can work if you're on an inpatient unit and you have a few days to figure it out, but probably not going to work in PES real well. It's probably not going to work in a lot of outpatient crisis type visits. You want to know right away. And, by the time the prior authorization comes through, you may be off shift. You may not be working with that patient anymore. So you really want to know. And it can be really hard. So this is just, some comments about that. The insurance companies will have many different coverage plans. You really should be able to find these online. And I'm going to show you in a little bit a screenshot of one. But please don't rely on printed formularies because they tend to get out of date very quickly. And so don't save like the PDF onto your desktop. Always just look it up real time if you can. And remember, your care coordinators may be able to assist you with that. So kind of going to our patient's tardive dyskinesia. He was on a commercial insurance plan. He was still working. He had some worries about adding another medication and the cost of that. It was really unclear to me whether he would be able to access that medication. So I went ahead and e-prescribed and let him know that it's probably going to require a prior authorization. And then we have great medical assistants over at the mental health center here. They help us with Cover My Meds, but that is the online system that we use to complete prior authorizations. And so they'll sometimes do the initial stuff for us, and then we have to go in and answer the questions. And for this gentleman in particular, it asked me very details about his antipsychotic use. Is he still on a medication? What's his AIM score? Strategies used so far, including the use of tetrabenazine, which is the old generic medication, VMAT2 inhibitor, that's approved for use in Huntington's disease, but not, for tardive dyskinesia. So, any thoughts or concerns? I particularly had a concern for using a medication off-label that seems to have a higher risk of worsening depression, the tetrabenazine versus the deutetrabenazine. I had been an investigator, a PI for a study that we did on deutetrabenazine, so I felt pretty comfortable with it for many years and saw some remarkable improvements in patients' tardive dyskinesia. And this gentleman in particular, I thought was a really good candidate because he didn't have terrible movements, but they were really bothersome to him. And he was very self-conscious of it, similar to the ads that you'll sometimes see on TV. That's who they're really marketing these medications to. Okay, so just think about that, and we'll get to the results of my prior authorization request for him. So successful medication prior auths really rely on a lot of things. So first, you have to have your accurate insurance information. So as much as you can, try to find that formulation information for the plan. And that can be difficult because people are on different plans. I'd say the Medicaid formularies are probably the easiest ones to find in New Mexico, just by doing a search. And then, think about, generics versus proprietary, medications. I always, try to encourage people to be fiscally responsible. Just as if someone's going to prescribe me a medication, I'll go for the generic, versus a name brand, first line, just because it's going to cost less, for me. And try to, remind yourself of that. Sometimes we don't do this at UNM, but outside clinics, they'll get a lot of samples and, they'll start their patients on the latest and greatest when they've never even tried an older medication, a generic medication. And so, that's really not fiscally responsible prescribing, in my opinion. Think about that patient, their specific, data. So you may not have the complete, treatment history. You may not have their medication history, but they may be able to, get that for you from their pharmacy. They may have come to you on, a list of medications, but you don't really know what they've tried before. But try to gather that as best you can. And sometimes we would have people who would come from out of state and they, probably had been tried on a lot of other things, but we didn't have that data, or they may be transferring insurance. So the insurance would deny the medication that they've been stable on because they didn't see that they had gone through those steps. When you're writing a prior authorization, really try to think about, what will be the objections to this? Know who you're writing it for. It's usually going to be a pharmacist if it's a pharmaceutical. So think about that and really try to tailor it to that individual. Make it hard for them to say no and easy to say yes. So, would see sometimes some of these prior auths and it said, patient is on this medication doing well. That's really not a good justification. They've tried X, Y, and Z medications before. This is the only thing that's worked for them. I may not have a complete history, but I don't really see a good clinical justification to change that. Is a lot stronger statement. So just kind of keep that in mind. Okay, so try to get that documentation if you're looking at step therapy, which is something that insurance companies will use. They'll say, okay, they have to fail, two prior antidepressants before they can get this latest and greatest. So, really kind of talk to the patients, talk to their family members, try to figure out if they've been through those earlier steps, even if you don't have that data, and record that somewhere. I took over, Dr. Cruz's clinic, and he was really good about putting that in the notes. He would have a list of medications that may have been tried. And so, with the EMR, it sometimes can be hard to find those notes, but if you can figure out a way to put it in your notes so that it carries over each time to each note, I think that can be really helpful and will save you trouble later on. Try to use generics first, and the specifics about step therapy will really vary among the different plans. So there's no hard and fast rule about that. And this can be a very time-intensive process. We had people moving from out of state, and oftentimes they didn't really know what they had been tried on. But we had access, working for insurance, we had access to different systems of prescribing data, and also like if they were like an Epic patient, you might be able to find Epic records from other facilities and be at least able to document that they have tried some of these other medications. And so, the costs, I really feel like this kind of takes me back to some of the initial papers that we did in general clinic when clinic first started back with Dr. Nurnberg. We reviewed the SSRIs back in the old days when the SSRIs were all name brand. And we really argued that having an open formulary was much more conducive to lowering the cost of care overall, showing fewer visits in the clinic. If you would just have an open formulary, at that point we only had 3 SSRIs, and but a lot of the companies were restricting the coverage to one preferred agent or another, and we were able to show, through a chart review like this, that the agents were not interchangeable, and that you could probably have a lower cost of care overall by having an open formulary. But the problem is that many of these economic studies are just focused on pharmaceutical costs, or they may not look at the total cost of care of that patient. And so there's some really interesting studies being done looking at that, I think, coming out from JAMA and the AMA to really support more open formularies. And then really, I think just be willing to look at the criteria and say, do these really align with clinical guidelines? So let me show you an example here. Okay, so this is just right off the website. This was not the insurer for my patient who needed the VMAT2 inhibitor, but this was another insurance, and this is right there on the Medicaid formulary. He did not have Medicaid, but it's just an example. So Austedo is the brand name for deutetrabenazine. If you look up deutetrabenazine, good luck, you won't find it. You have to look up the name brand. So if you're not finding on the formulary, look at that, look at the class, look at the, search for the name, but it can be really frustrating. So if you see on here, I show the different ones, the formulary versus non-formulary. So Austedo is listed as formulary, but on the right here, you'll see, QL for quantity limit, PA for prior authorization, and I can't read the other ones, they're not as important, but there's like an age limit. So the next slide shows how step therapy may not be consistent with treatment guidelines. So here's a list of what, if you're going to prescribe deutetrabenazine Austedo for tardive dyskinesia, these are the criteria for Medicaid. So first, you have to be in consultation, medications to be prescribed in consultation with a neurologist or psychiatrist. I think that's reasonable. You have to have a documented diagnosis of tardive dyskinesia. They'll sometimes ask for your AIM score. I think that's reasonable. But number 3, trial and failure of amantadine. That is no longer a clinical guideline. That was in the neurology recommendations from probably 10 years ago. It's since been removed. It's not fitting with clinical guidelines. And I think we have to hold companies' feet to the fire when they put stuff like this into their formularies to say, hey, this is no longer practice. This is against what the clinical guidelines are recommending. And then the person has to be on at least 60 days of stable drug. That's fairly reasonable. Or they may have had medications, some of the older things for used for nausea. Some of the worst tardive dyskinesia I ever saw was from a lady who just had compazine prescribed for a few days post-surgery. It was horrible. And then, of course, do your AIMS exams. We're supposed to do those every 6 months, but do them more frequently. If you have someone on these medications, always have a current AIM so that you can really, fight for your patients. All right. So some additional considerations. Just remember, off-label, you probably will not get that approved. And I think that's, fairly reasonable. Kind of check the medication label against the age of your patient. Remember that the pharmacists are often screening these initially, and then we'll send them to a physician if there's a question. So if you have to go to that doc-to-doc, plan ahead. Really know your patient well, and don't be guessing on this stuff. Don't make stuff up. Don't guess. Have as much data as you can, and make it, again, easy for them to say yes, hard for them to say no. Gather any evidence you have, the clinical guidelines, any supporting documents, and again, use those care coordination folks, because they may be able to tell you, oh yeah, this person had this previous provider before, and so you may be able to get those records and find out what else they may have used. And they can often pull up that pharmacy data as well. So tell a compelling story. When I did this prior authorization, the plan wanted him to try tetrabenazine first. It's not approved for tardive dyskinesia. So the 2 FDA-approved medications are deutetrabenazine and valbenazine. I did an internet search. I found this great VA document which examined these medications, and they quoted numbers for how many people had been treated for tardive dyskinesia, and it was like a total published database of about 40 patients for tetrabenazine, about 400 for deutetrabenazine. So in my prior authorization, I quoted this document, I attached it to the record, and I said, I do not feel that tetrabenazine is an appropriate choice for this patient. So, other people may have done this a little differently. I tried to answer all the objections I could, but surprisingly, it was approved the first shot. There were some hiccups with obtaining the medication. Often these medications and the LAIs will require specialty pharmacists and pharmacies, and so they didn't tell me that, and it took me a while to figure it out. I called it into the specialty pharmacy. He never got it. I called back, and they said, we have no record that you called it in. I mean, it was unbelievable. He finally got it though, and he reported that his copay was affordable. He wasn't having side effects, and he thought his movements may have improved. So I've slowly gone up on the dose, and so far so good. I haven't had any problems. Most of those prior authorizations will require a 1 year, every year renewal. So just keep that in mind. And I always save what I wrote. I save it, without patient identifiers on it. And I try to reuse some of those documents because it's often in different insurance companies. So you're not, talking to the same one. But if it's successful, I try to reuse it. Okay. So we're running a little short on time. I want to leave some time for questions. But this is just kind of a chart showing that many of the mental health benefits is, in addition to other benefits, are requiring prior authorization in Medicare Advantage plans, which you won't have in traditional Medicare. And as far as what guidelines the insurance companies use, there are different ones. So for substance abuse, we have the ASAM criteria, and those are 3.5 level of care, 3.4, 3.2, all that. And they're pretty, it's kind of like a menu, like a Chinese menu approach. But at least it's a published guideline. It's a book. You can look at it. You can write to it. The ones that we use were these MCG behavioral healthcare guidelines. Those are available online. Medicare has national coverage determinations and local coverage determinations. And so if there's a determination, like for example, TMS is a Medicare covered, benefit. And so, they're using those national coverage determinations. So that kind of helps access to some of those services. And always ask what criteria are being used. So we have another example. This was an ECT request. And so the company I was working for suddenly started asking for doc for every ECT prior auth. Nothing else had changed. We had discussions back when I was working for them to remove ECT prior authorizations because we essentially, people are getting to ECT, they're usually pretty ill. And so I asked the attending who was having to do these, what criteria, asked him to ask the company what criteria are being used. And he was actually told that they were using TMS criteria, which is, like so much stricter. And it's like the physician on the other end of the phone didn't even understand that TMS was different from ECT. I mean, it was really pretty egregious. So I always document who I talked to, what the outcome was, and consider making a formal complaint. Like, I think this should be a formal complaint. Put this in writing. Let the company know that they are, creating barriers to people getting ECT, which is, a life-saving service. All right. So what happens if your PA is denied? Then you have to appeal. And a lot of times you will get some information about that, but those letters will go to the patients. And so you may not, know about the appeal until the deadline is almost up or past the deadline. And that's just, unfortunately, the playing field that we're on. But overall, people in Medicare Advantage will often have to go through about 2 prior authorization determinations per year. That's the average, staying fairly constant across different years. And rates of prior authorization denials for services are actually quite low. So, staying under about 8%, fairly consistent across the years. But for people who do have a denial, very few, on the order of about 10% of those are appealed. So what happens when they're appealed? Very high rates of overturning. So more than 80% of denied prior auths that were appealed were overturned. So think about that. Your patient, very few people will appeal. Most people are not getting a lot of denials, but the ones who do appeal, if 80% of them are overturned, they probably shouldn't have been denied in the first place. So I think sometimes people are not very careful when they're looking at the data, on the insurance company side. It's easier for them to just issue a denial and to hope the person doesn't appeal. And so really we need to challenge that. Those letters will come in, like I said, to the patients. They usually will have instructions. they're complicated. I mean, I've looked at some of those letters that I've received, from my family members, and I think, man, how is like the normal person supposed to supposed to figure this out? Plus, there's pretty high rates of illiteracy in the population, the adult population. So some of them have a very short deadline. I appealed my uncle's denial for continued, rehab services after hospitalization. And they basically told me that I didn't meet the deadline, and I couldn't even get through to anyone to start the appeal. So they're very quick to kind of tell you, okay, your appeal, you missed the deadline. So be mindful of that. Sometimes there's 30 days, 60 days. It can be very quick. And the patient may need to initiate it, but they may need help doing that. So really encourage them to have their family members help them with that. I will sometimes let family members know when someone is having a denial, especially with Medicaid, to advocate by calling the governor's office, because really that is sometimes the only way to get the attention of a Medicaid provider, because these are rules that they have. They're supposed to be administered, fairly. But if you're having a lot of issues, if your patient's having a lot of issues with barriers to care, I will often kind of coach families about how to make that call. And the way I would do that is I would say, say I'm a constituent. I have a family member who has repeatedly, has been repeatedly on many different medications, is being denied for this one care. It's the only thing that's worked for them. Or I can't get them into any kind of assisted living. I'm being told that there aren't, that they can't do it because there are rules and this and that. And oftentimes the state will then issue a deliverable to the managed care organization. And I have to be honest, there were times that I was working on getting a service for somebody, getting them into assisted living, something. And until that family member or, caring person made a complaint, what was taking me months, now suddenly the state's saying, this is a deliverable, you need to let us know by end of business tomorrow. And sometimes I saw stuff that, got approved within 3 days. So, try to work with them, but as a last resort, I think encouraging family members to really advocate with elected officials can be very, very helpful. Okay, so here are my conclusions. Really knowing the rules, that's half the battle. And, sometimes they can be hard to find, but, I didn't include AI in this talk because I really am not very versed in that, but I think that it will get easier and easier. But that will they'll be using it on the other side to make things harder. So it'll probably all, even out. But you can use, searches to find documents to really support your contention and support the needs for the services that your patient may require. Really be thorough in your documentation. There's this line on a lot of inpatient, patient requires continued hospitalization due to, risk of harm or whatever, but be specific, so be really thorough, document that, try to make things, like I said, easy for them to approve, hard for them to deny. Call on those care coordinators for assistance, especially with New Mexico Medicaid. Appeal those denials when it's practical. And really consider encouraging those family members and loved ones to ask for help from the state. And so that's the end. I don't have, let me escape out of here. Let me go back to see if there are there's some things in the chat. Are there any questions, anything I can answer for anybody? If you have specific concerns, feel free. If you want to talk to me about specific patients, we can do that offline. Not today, because I have to run off to Phoenix for a geriatric psych meeting, but I will be happy to talk to you. And I want to try to be a resource and demystify this stuff, because it is not easy. All right, I don't see any questions. Robin, do you see any questions, or does anyone want to just unmute?
I don't see any questions, Dr. Hensley.
I can ask a question, Paula,
All right,
or
great.
Dr. Hensley. Or just a topic for you to talk about. In our system at UPC, we have some patients have what are called CareLink New Mexico coordinators or CareLink
Right.
coordinators. Can you address them a little bit? So that's the care coordinators that you're mentioning, but why they're called CareLink New Mexico and how that might differ from a case manager
Yeah,
or peer specialist.
yeah, and you may know more about that than I do. I mean, we had some managers in our company who were kind of in charge of the Care Link, and so sometimes, those were like UNM employees who were part of that Care Link process, and so they know the UNM, excuse me, services really well, but they may not know all the ins and outs of insurance. But they can sometimes join in on case staffings with the insurance companies to get that specialized knowledge. So, I mean, I think it's part of that health home, and I don't honestly really understand kind of how that all works. And I think that would be a great topic for future education. But they're kind of more embedded within the system here at UNM. And they do have linkages to the insurance companies to get that information that they may need, that may help them as well.
Thank you.
Okay, sure.
Good talk.
Can I ask a question, Dr. Hensley? This came up from more of a national listserv I'm on that has, psychiatrists in different areas, and a lot are in private practice. And the topic of PAs came up recently, and a lot of discussion about, like basically saying they needed to charge patients, right, for the time they spent doing PAs. And I mean, I know in our system it's a bit different, but certainly like the case you described, is very time consuming, and, different people work in different systems where, they have just the various reimbursement models. Have you heard more about like how people approach that? Or I do think it's valid to say the time, in different systems, could be a significant factor.
Right. No, I agree. This can be very time consuming. And that's why, I try to, like I said, I try to save my work and reuse it, because sometimes it will come up. The same issue will come up. From my understanding, I don't know that you can really, I don't know of the ability to charge for that service because you're not face to face with the patient. Now, if you do it on the day that we're seeing them, I think you could probably include it in the time spent because you're reviewing the chart and you're doing all that. So, someone who is more adept at billing would probably be able to answer that question better. But, it's yet another one of the things that I think, insurance companies try to use to put that barrier up, because they know that we really don't have that kind of time, to do it. And so they're kind of counting on that to make things easier to deny and everything. So I think that's even just prior authorizations in general have been linked to, burnout and dissatisfaction in physicians. So I think that can be a huge problem. So I will let you know if I hear of anything more. And at this meeting, I'll be going to the geriatric meeting. That might end up being a topic of discussion as well. But I encourage people to share information on these things, on these topics, because I think we can all be a resource for each other with that.
I agree. It doesn't seem the most patient friendly, but it does seem like for time you could have them sit there while you work on their PA, which I mean, I don't know that that's the best or not, but.
Well, not so much with them, but you can, if you bill on the same day, like afterwards, it's still on your own time, but you can still include that in the total amount you spent on that day. Yeah. So like, when you're reviewing the chart now with, communicating with other providers, if it's all done on that same day as a visit, you can include that is my understanding with the billing amount. Yeah. And the other thing, we didn't go into this, but, people will also often bring paperwork, and I know docs are trying to charge for that. And I think that can be a legitimate thing. Whenever I do paperwork for a patient for like FMLA or whatever, I always actually do it with them because, I want them to feel comfortable. I kind of don't think it's an employer's business what their disability, what their reason for asking for this accommodation, but I also want to make sure that they're comfortable with what I'm saying. And oftentimes the patients will say that they're able to work more than I would probably estimate. So it's also been good in that sense, just to get a more accurate read on that, like what sorts of accommodations they need. All right, any other questions? Oh, thank you, Monique.
Great presentation, very helpful, Dr. Hensley.
All right, thank you. All right, thanks.
Strong work, Paula.
All right, thanks, Dr. A. Look at you at your ECT.
Yeah, hey, enjoy the trip too. But
Thank you.
yeah, hope you have a wonderful weekend at Phoenix. We'll see you when you get back, okay?
All right, thanks so much. Thanks, everyone.